right, welcome everybody to the Health Impact Live webinar on patient outreach and re-engagement for effective care coordination and prevention in this COVID era. We've got some fantastic panelists from Microsoft to talk to us about this very important topic. And instead of covering it purely from a technical angle, which many of us are always accustomed to when we hear about digital health, we actually are going to cover it from multiple angles. So we've got an MD, we've got an RN, and we've got a technical person, and then you've got me, who's a little jack of all trades, but I'll be helping to moderate and keep the discussion going. As usual, that is very common in our Health Impact events. We'd like for you to ask questions. So in the panelists, you guys are all muted at this time, but if you have any questions at all, please drop them into the Q&A panel that's there, or if you can't find that and you find the chat, drop it into the chat. We will pick that up in about half an hour or so when we start to open up for questions. But if you say something super meaningful in the chat, etc., and I notice it, we might pick it up and discuss it during the discussion as well. This presentation, of course, is being recorded, so you'll be aware of that, and you'll receive an email with the link to the recording in case you had to step out or are busy during this time as well. With that, you know, from a topical perspective, you know, we've heard a lot about patient engagement in general, but how do you actually use patient engagement for outreach and getting the re-engagement going in this time when lots of people have delayed care for obvious reasons with the pandemic? Sometimes they were asked to delay the care, sometimes they delayed it because of fears. So there are a lot of things that are psychosocial in this nature. There's a lot of stuff on the political end, but there's some of this that we can handle through technology. There is some of this that we can handle through a lot of tools and solutions that are out there. And so we're going to talk about it from both the patient angle and what their fears and stuff might be, certainly from the provider angle, but really talk about what can practically be done. And that's really what Health Impact is mostly known for. So with that, you know, we're going to go ahead and open up and let our panelists introduce themselves. They'll give us a very quick background of their role at Microsoft, what they do, and more importantly, what does that role and what they do help in this topic of patient outreach and re-engagement for more effective care coordination and prevention? With that, David, I'd love to start with you.
Thank you, Shahid. A real pleasure to be here. Hi, everyone. My name is David Rhew. I'm the Global Chief Medical Officer for Microsoft. By way of background, I'm a physician, I'm a technologist, I'm a health services researcher. I've spent the past 25 years looking at how technology can be used to improve health outcomes. So specifically access to care, quality of care, improving patient safety, finding ways that we can improve the efficiency of care, and also the experience that both clinicians as well as patients can have. So super excited to be here. Happy to share my thoughts.
Awesome. Welcome, welcome, welcome. Tony.
Thank you, Shahid, and thank you, Health Impact, for having me. My name is Tony Thomas, and I am the Chief Patient Experience Officer for Microsoft U.S. Health and Life Sciences. I have been out in the industry side of things for about 15 years with a focus on analytics as well as the experience, patient experience, consumer experience. And prior to that, I spent 17 years practicing as a nurse practitioner in pediatric critical care. So really my role within Microsoft is to understand what's happening in the market around experience. And that's really interesting right now, and we'll talk about that in a little while. And then bring that back into Microsoft, so develop that point of view. And then that in turn really helps how we develop and prioritize our solutions and then take them out to the market.
Yeah, that's fantastic. And you know, one thing to learn in the audience from both David and Tony is they're not window dressing at Microsoft, right? They're not the little MD and RN that you attach to make sure that you have some medical background. I mean, they're actually leading and telling product owners, product designers, and others about how to take solutions into a world that can be more and more practical. Now, into the solutions world, into the product world comes Hadas. Hadas, tell us a little bit about yourself.
Thank you so much, and thanks for having me. It's great to be here. My name is Hadas Bitran. I'm the head of Health and Life Sciences in the Microsoft Israel R&D Center. I'm managing a multidisciplinary engineering group that is focused on artificial intelligence in healthcare. We develop health-specific products and technologies that are being used by healthcare organizations all around the world to help them improve their services and engage with their patients.
Yeah, and what's fascinating about the role that Hadas has is that the input that is necessary, especially because you're currently speaking to us from Israel, there's a lot of really new technologies that you're able to incubate in a country like Israel. And so obviously you guys got through the vaccinations a little bit faster than we did. We learned a lot from that area. So Microsoft having a center out there where they're actually learning from the society, pulling that back into products and solutions, and then being guided here from the US with team members like David and Tony is just fantastic. So with that, let me just start off, Tony, with you, and that is that we're a year into the pandemic, and almost a decade has happened of adoption after meaningful use and all of the other regulatory requirements that we've had. But some are going to argue that patient and provider experience and the expectations, especially with respect to digital health, have changed more in the last year than in the past decades. So as an RN, do you agree with that? That, really the world has changed dramatically in the last a year or so? Now, since you're there in the Cleveland Clinic area, obviously a bastion of thought leadership as well as actual practical day-to-day care, tell us what you're seeing with respect to on the ground, how much change has actually occurred in patient engagement, especially given that Adrian Boise, who's a Chief Patient Experience Officer at Cleveland Clinic, is helping you in your area as well. So tell us, how big a change has it been in the last year and a half, and what has Microsoft learned from that?
Sure. So I would say that I've talked to a lot of healthcare leaders here in the Cleveland area and across the country, Adrian being one of them. And I think it's safe to say we have had like this rapid and seismic transformation, and that has happened because of out of necessity, because we had a pandemic. So yes, a lot of transformation. I would say that there was demand for transformation prior to the pandemic. David will probably validate that, but it just accelerated things. So there's a few things that we're seeing here. I'm going to talk a little bit about the care side, the care providing side, the nursing side, the provider side. So, these are creative people, and they had to make really rapid shifts in how they were delivering care, again, out of necessity. So we saw that rise in virtual health. Yes, I live here in Cleveland. I am a patient at the Cleveland Clinic, so I can tell you they already had a solid digital front door in place for their patients, and they were using things like health bots for outreach. And I had a couple outreaches during the pandemic about like my colonoscopy had to be canceled and rescheduled. So we're seeing those things, and I think those are just going to continue. We can't go backwards. I would also say inside the hospital systems, inside the hospitals and the four walls of the hospitals, we're also seeing how care has kind of shape-shifted. I've recently been reading about the rise in virtual nursing. So the use of a virtual nurse sitting in a room who is monitoring via remote patient monitoring a group or a panel of patients, and then communicating with the nurses on foot on the floor. So we're seeing more of those things. You mentioned something interesting earlier about getting patients back inside the four walls of the hospitals for things like their necessary routine screenings or examinations where they need to be monitored or have labs drawn. And what we're seeing at Microsoft is a shift in really focusing on how the health systems are outreaching to patients to do that. So we're seeing an uptick in interest in CRM, but not your standard everyday CRM.
And what would you color that commentary around that CRM? What are they interested in that's different than everyday CRM?
Yeah, it's not just your standard run-of-the-mill marketing-focused CRM. This CRM really needs to be intuitive. It needs to be cohesive between patients or consumers and the people using the CRM. And the people that are using the CRM are actually expanding. So we're seeing people like care managers and care coordinators and utilization managers and patient access people start to utilize the CRM. So this CRM has to be personalized. It has to allow the patient to feel known. And then it also has to allow the end user to understand insights about that patient. It really is a form of a longitudinal record.
No, I love it. And in fact, when you think about that, David, I'd love to bring you in and talk about, from your perspective, how have the patient's expectations really changed? Healthcare is famous for taking a long time to change the standard of care. You've heard everything from single-digit years up to 17 to 20 years for standard of care changing. We get the idea. Basically, what Tony is saying is that year and a half, over the last year and a half, we've seen that shift seismically. Do you agree with that? Is that a seismic shift? And now the expectations of the patients are that things really will change faster in healthcare? Or do you feel like things will kind of like rubber band right back to the way things were after this? Obviously, care is more virtual now, but tell us what that really means in terms of what's going to stay rather than just where we are temporarily.
One of the biggest challenges that we face is change management, and individuals that are used to doing things a certain way, it's difficult for them to want to change. But when you're in the midst of a pandemic and the only options you have available are things that force you to learn new systems and learn new approaches and try things out, you realize that innovation ends up becoming the stimulus for how we can rethink what is the new standard of care. I'd say from the very beginning of the pandemic, the first things we saw that we didn't recognize early was that when a large number of people have questions and they need to be answering those questions all at the same time, it creates an overload to the system and the systems crash. And this is true with whether it's a call center or whether it's an EHR for scheduling vaccinations. And what we realized is we had to build capacity into that, and that meant innovating, taking some of the tools such as a chatbot and converting that into a COVID screening bot or to an ability for us to handle the demand for vaccinations. It was an incredibly innovative time period, but it was seamlessly brought into the patient experience realm so that they actually now didn't see the challenges that others were, which were those delayed wait times and the fact that they couldn't get through. And so, the technology, sometimes the best technology is the stuff that's behind the scenes. You don't even realize it's there. It's helping. To Tony's point around, CRM and how we can start thinking about how we can reinvent or rethink what CRM can be. Today, a lot of it is just around managing the current workflows and, triaging. But what if we were to think about CRM as a way to help every individual who is touching an individual's care to be empowered to the top of their license to be able to practice? So let me just give you like one simple example on that. If I were to make that phone call and I've got concerns about COVID and I feel like I need to come into the hospital, and now that I've got the chatbot, I was able to recognize that that this is something that then gets escalated to a call. Well, if that were the case, usually what happens is the person who's at the other end of the phone line will schedule me or connect me to the person who does scheduling, and that's about it. It's a single purpose encounter. But let's imagine I have actually struggled trying to get to my visits. I live far away. I've been having financial challenges. So transportation's an issue. I don't have a car. And on top of that, it's likely that these will get worse because of the pandemic, because of the lack of public transportation and concerns. So what would be great is if somebody were to identify those needs, perhaps through the fact that we can use FHIR APIs, pull data in, do a quick assessment, and understand that you've got some unmet needs, these social determinants and social influencers. They connected me to the programs that could help me. Transportation, food, housing, jobs. And then they were able to address that at the time I was scheduling my appointment. So it's, again, the concept of right information at the right time but this time being deployed by individuals who are not necessarily your healthcare physician, but the entire healthcare team. And it's something that we saw during the pandemic, where the bot was an amazing tool that allowed us to connect people to programs. In this case, it was connecting them to clinical trials or connecting them to plasma. It's the same concept. Technology can help us connect to the programs and to the services that we know are available, but sometimes we just don't do because we're too caught up in the moment.
Yeah, and I think, David, you couldn't be more right. I mean, prior to the pandemic, it felt like those of us who were talking about bots and this idea of engaging patients in a more personalized, like bots are not less personal, they're actually more personal. They were kind of felt like a novelty to the innovation department. You know, before the pandemic, it was like, yeah, if the innovation department wasn't trying chat, they weren't novel enough, but they really treated it as a novelty, not just novel innovation. How much of that has really shifted here? Is that bots are no longer a novelty, and now if you're not using it, you're never going to get to the personalized re-engagement that you want? Is that kind of like the point you're making?
Well, I think what the innovation and the realization we had was we came up with one purpose for a bot originally. It would help in a customer service encounter where you could ask a question and it could help get you to, and in many ways, either an answer that was in a database or perhaps an escalation. That was sort of the general concept. What we're now realizing is the bots can be used to connect people to programs. It can be used by not just the consumer, but by the healthcare team as a decision support tool. So there's so many interesting ways that we can apply this that are part of a clinical workflow that leads to us having a more seamless experience.
Got it. Yeah, perfect. So speaking of seamless experience, Hadas, as you think about what's changed on your side as a builder and as a manager of other developers who are trying to build these things, tell us what's the most incredible thing that you've seen in terms of innovation. It could be within Microsoft, it could be outside of Microsoft. Just what has surprised you and how quickly innovation is taking place? And maybe if you want to relate that to what are some of the interesting ways that the health systems are re-engaging with their patient? Is the bot the extreme sense, or is that the starting point and there's a lot more that they can do?
Yeah, absolutely. So COVID-19 definitely created an inflection point that has accelerated several trends and impacted us as builders of technologies. And I want to refer to a couple of those trends. So the first one, I guess, is the rapid rise of virtual care in operations, including the integration of the virtual and physical across the care continuum, which I believe will continue. So video chat and chatbots are here to stay, and we see the broad adoption. Specifically in chatbots, we see a significant uptake in the adoption of the chatbot technologies that are supporting those virtual health assistants. They aim to put more information, credible information, in the hands of patients and handle some of the burden on the provider organization to improve services, improve their processes. If we look at the story of our HealthBot as an example, I can tell this example because I was closely involved in it and our team was heads down working on it. HealthBot was a service that we created years ago to empower healthcare organizations to build their conversational AI health experiences that are intelligent, personalized, but also meeting the healthcare standards in terms of compliance and offer access to health-related information. It had good adoption over the years, but as you reflected it, those were considered novel, and many people were skeptical about chatbots in healthcare. And then COVID-19 hit. In the early days of the pandemic, the Providence Health System reached out to Microsoft to ask if we could help them triage the flood of incoming calls from people that had possible COVID symptoms. And our service, which we have built to scale, could easily do that. In less than 2 weeks, Providence patients used it for more than 40,000 encounters session. We've worked closely with the CDC. My team has worked closely with the CDC. And by the end of March 2020, after working nights and weekends with the CDC on their symptom checking protocols. We had more than 100 health systems all around the world that were using the same protocol to triage incoming calls. The most overwhelming thing for me is that today, HealthBot was implemented by thousands of healthcare systems all around the world. We have 26 countries, and we served more than 100 million people all around the world with 1 billion messages during the last year alone. We've seen this innovation grow. We've seen this being adopted not just for symptom checking and triaging, but also for self-serve assessment questionnaires that are used in scenarios like return to work, in vaccine eligibility check, vaccine scheduling. So this is one example of improving processes through technology that is being used in virtual care scenarios. Other examples include tools like ambient clinical assistance or clinical ambient intelligence, sometimes they're called, that are lightening the burden of the clinical documentation. That's also a technology quite innovative that we see an adoption of. And we also see acceleration of decision support tools that are based on analytics and data. And as David mentioned previously, an interesting example in this area is the adoption of our clinical trials matching technology together with our health NLP technology to allow finding clinical trials that are based on eligibility criteria of the trials and the patient information. And this was adopted to expedite the recruitment for COVID-19 clinical trials. It definitely surprised me to see such quick adoption, and I was pretty pleased with the readiness of our technology in terms of scale and the ability to provide the needed services in a robust and compliant way.
Yeah, and I would say that I was actually less surprised because you guys have been pushing this out on the cloud. So one of the reasons why healthcare technologies are so difficult to get embedded is often you have to install stuff, then you have to train people, and you're doing this in ways that are not the same as the consumer experience that they get outside of the hospital, whether it's the employee or the patient. What's really cool about your tech, though, is it's the same tech you're using on the consumer side. So consumers, if they're already using Windows at home or on their Mac OS, they're using their iPhone app, et cetera, they're translating directly. So when they come, they're using the hospital system, but on stuff that they're just fully familiar with. Same thing happens inside hospitals and telehealth systems. So how much of that do you think helped move things along, that nobody had to install anything anywhere behind the firewalls at hospitals, and that you could get all of this in the cloud, robust, secure, privacy enabled, et cetera? How would you comment on that, Hadas?
I don't take this for granted. We're investing a ton of work in security and privacy. We were ready because we've done all that work in advance. It's a big, heavy lift. It takes a long time. But we were ready with all those security capabilities and in our technology, which allowed us to respond very quickly. It was already out there. I do agree that having end users use the technology that they're used to, chat with a chatbot over a mobile phone or within a search engine, or use web browsers as means to communicate with their providers, had a lot to do, contributed a lot to the adoption of those technologies. But we should say that we invest a lot in the security, and I would argue that nowadays, with the major investment in cloud security and the effort that we do in order to defend the products, you could say that in many ways the cloud security is more robust and stronger than the on-prem security, because the cloud will always be patched and up to date with the latest security vulnerabilities, and your on-prem system will be as updated as your local IT made it updated.
No, that's great. And as a technical person, you get a gold star for not saying AI in your remarks here, but I'll say it. You know, underpinning all of this is, of course, a whole bunch of AI. But like David said, if it doesn't disappear and you have to talk about the AI, you're not doing something right, which is why I'm glad that you didn't talk about it. But the really cool thing is that class, who are obviously a lot of our hospital colleagues end up using class to help determine, you know, who are the leaders in these spaces. Class recently recognized Microsoft's momentum in healthcare AI, and hopefully somebody will put that in the link here, because I think it's a good report to read that talks about what is the reality of AI versus a bunch of BS that's going on, and I'm glad that you guys saw this. So Tony, bringing you back in, you know, we've seen now that you know, the patient first approach to experience, right? Build your experience. So you think about the patient first before your employees and before your institutions is really the right way to go. But it's really hard, right? Because an institution, a healthcare institution, sees patients all the time, but they don't really know what's going on inside their patients' lives all the time. So what are the big challenges in health systems being patient first? How do they get to learn what do patients want, and from an expectations point of view, but really from a delivery point of view? I mean, everybody says I want cool tools, but how does a health system know which patients need what and be able to deliver that?
I think that, and we're experiencing this right now, but there's a paradigm shift taking place, and we need to fully move through this paradigm shift. So we have what we know as traditional patient experience. That's been going on in healthcare for a very long while. And then we have what is really bubbling up as a consumer experience. And these two things are converging. And I think that the pandemic gave that a lot of momentum. So what we have been seeing is healthcare systems are really trying to offer this traditional patient experience, but they look at consumers as patients. And they really need to look at them from all views. These are people who are consuming healthcare services. So I think it was maybe you, Sahid, that mentioned that, you know, a lot of Microsoft technology is underlying these other digital experiences that consumers of healthcare are having. They're having them in banking and finance. They're having them in retail. Like if they have the Walgreens app and they're a Walgreens loyalty member, they're using Microsoft technology under that experience. So this is the type of experience that healthcare systems really need to come forward and offer their patients. And I use the term digital front door a lot, and that's a term that's used very widely. But the way I like to talk about this with healthcare systems is that digital front door, when a patient or a consumer opens it, they need to feel like they're at their home in that place. And other industries have been able to do that, and healthcare has been lagging. So we have a lot of catching up to do. And then once that front door is opened, you can capture the hearts of the patient, which is really the trust, the mind, and the attention. And that's by knowing the patient. That's by knowing things like where they live, what sort of places they shop at, what services they access, social determinants of health, because we need to address health equity. And then once we know all those things about that consumer, then we can help healthcare systems capture their loyalty. So I really think that that's what we're driving at Microsoft in the health and life science realm, and specifically through how we're utilizing things like CRM, so our Dynamics product, and with Teams.
Yeah, and Tony, the big lesson there is that often we hear the word kludgy, you know, when we run an app or use a system, and we're not quite sure what's wrong with this, but we don't quite like it. Often that's only because we're familiar with one thing and not another. So if you took the Windows experience, or if you took the Office experience or the app experience and just made it look like that, the chances that someone will know that experience is more than whatever small system you might buy or build on your own in a hospital. So continuity of experience from iOS, from Windows, from a phone on the Android side, that seems to be what we need to strive for. not because it is the best way possible, but because it is the most convenient and least thing that they have to, that consumers have to go learn, which is why I really love the chatbot part, because consumers outside of healthcare have been using it for years. So when they had to use it in healthcare, they weren't saying, oh my God, what are you doing? They were like, finally, right? So in terms of the word finally, David, what are the other things that now, using this experience of the last year and a half, we can say, finally, guys, you can use these other solutions that have been sitting here for a long time. You know, Mr. C-suite member of the hospital and health system, here are solutions, go use them. That's one area. And maybe if you need to build something, you don't need teams of people for 9 years to go build it. You could take one guy who knows how to build a website, throw together an API, hook up on Azure, and go forward. Which one would you recommend, you know, from a solutions or a building perspective?
Well, you know, one of the amazing things about the pandemic was that we began to see that acceleration of digital, but a large part of that work was being done well before the pandemic hit. And one of the things that we had recognized long before was the challenge that clinicians and patients have around burnout. Clinicians are, and you can look at surveys of physicians and nurses, about 50% of them are burned out, and that was before the pandemic. I mean, think about, you know, what the levels are now. And a large contributor to that was documentation into the electronic health record. I mean, it was these administrative burdens that we had added on top of that. And that has a direct impact on patient encounters when the doctor and the nurse are too busy focused on the screen and less on you. They're not paying attention to anything apart from what they need to enter into the system. And that's not good for patient care, that's not good for the experience. And most importantly, when you have doctors and nurses leaving the profession because of burnout, that's not good for anyone. So one of the things that we had been looking at was, could you take some of the administrative burden out and automate it using voice? Now, we have seen a lot of voice technologies which are more translation or dictation services. But what we wanted to do was apply a mechanism where not only would it do voice to text transcription, but it would understand the context of actually what was being spoken. Who was speaking? Was it the patient, or was it the physician or the nurse, or the family member? And be able to separate out what was clinically relevant and what was not, organize it into a clinical progress note or a history and physical, and then integrate that into the medical record. I mean, all those steps, each of them a task on itself, we had been working on for years, and through a partnership with Nuance, we launched a product during the pandemic, you know, the Dragon Ambient Experience, or DAX. And that is, in many ways, going to be a transformative technology for both the clinicians as well as the patients. And what we recognize is, while a lot of visits were being done virtually, we also needed to make that a virtual component. So we embedded that within Teams. And so you actually now have a virtual capability to be able to address this. But I see that as really just the beginning, because a large part of what healthcare is about is understanding context and then helping provide that decision support. So if a system understands what we're now talking about, we can start envisioning decision support systems that are more precise, that allow us to become much more targeted towards identifying gaps in quality and safety, and potentially even helping regulatory and or reimbursement. So the opportunities are significant relative to the use of these newer technologies. And the adoption will continue to increase as we start seeing more and more people trying it, realizing that this is an incredibly powerful tool and that we can do so much more than what we currently do today.
Yeah, and I think the word integration comes to mind here. Is you need the scale of a company that can understand multiple industries, multiple sectors, cloud and on-prem, to actually combine all of this and put it together. Last year at Build, so I'm a software engineer, so I listened a lot what happens at Microsoft Build. There's a great example of this in what you were just referring to, where they showed an office. You guys showed an office building, a room where people were coming in and out of the room talking. And then in a meeting, people were speaking to each other, and the natural language processing, the bots that were listening on Skype and all of the teams, they knew through audio, through video, who came into the room. So they knew that Shahid came into the room and left the room. Then through audio, it knew that Shahid spoke, transcribed it, and not just, it didn't just say some guy. I mean, it said Shahid using his voice, and it had it would have my name next to there. That context that you mentioned is so important. But if you don't have integration, if you don't have integration with the video, and you don't have the audio, and you don't have the operating system to be able to connect it, and you don't have the apps and the cloud to be able to pull all this together, that seems like it's really, really hard to do. And I think that's why Hadas, recently Gartner mentioned you guys as a leader in the Magic Quadrant for AI. Talk about why did Gartner feel like you guys were leaders in that space? What is the idea of natural language processing, chatbots, et cetera, that is so that requires so much AI? I mean, what's the big deal?
I actually have a humble view about AI when it comes to healthcare. As sophisticated as we're building it to be, I personally believe that AI will never replace the doctors and the medical professionals. It will augment the humans. It will help them do their work. There is a lot of investment when you create artificial intelligence for healthcare, because the types of data is very diverse. It's also very technical, like medically technical. So there's a lot to understand. You need to actually create all those services that we have in the general domain. You need to make them understand healthcare. It's not just text analytics. You have to adapt it to create text analytics for health, for it to understand medical terms, for example. Chatbots need to have protocols in them and understand the medical terminology and the clinical context to be effective. And artificial intelligence can be used to effectively scale healthcare if it's done properly and reduce the burden from the system. It can automate processes that can be automated, that you don't need necessarily a human because they're very technical. It can help put more credible information in the hands of people. It could also help you support decisions with data. So decisions can be taken not just based on the gut feel of somebody or just their memory or experience, but actually base those decisions on data. And it can also help doctors focus on what's most important. And I believe that what we're going to see in the upcoming years is that the combination of cloud, the responsible use of data, and artificial intelligence can and will contribute to better healthcare services, more personalized care, better decision support, and can promote the clinical research that can eventually help clinicians save lives.
No, I love it. In fact, as we were talking, there were some obviously questions coming in from the audience, and we're going to take the questions in about 10 minutes. But there's such a good one came up from one of our audience members, Sumitra, mentions in the U.S. virtual care has reached adoption levels at over 40%, then started dipping. Globally, we need sustainable virtual care models. And while deep tech is being adopted, the model is still broken. We don't have dynamic data. We don't have a true communication, fractured experiences. The transition to physical care is not really connected to digital. It's like digital is in one world and physical is in the other. So they're wondering, there is not going to be one size fits all here. But what are some best practices around patient outreach, care coordination, so as to provide appropriate interventions? It's a long question. Provide appropriate interventions and improve care. And more importantly, how can AI be effectively used to better things? David, if you can talk about the clinical side, we saw a dip. Is that dip odd in your opinion, to be expected, not to be worried about, et cetera? Just some color commentary there. And I'd love Hadas to talk about the AI piece, but then Tony, really, from a care provider perspective, to talk about where does AI really matter on a day-to-day basis so that it's gone, it's kind of like disappeared. So David, clinical side, then we'll jump to Hadas and Tony.
Okay, sure. Well, I think one of the first things that we recognized was there was that early jump towards virtual care adoption out of necessity. But we also saw several barriers and challenges. And these are things that we are now recognizing, that if we want to move to a digital age and we don't want to leave the most vulnerable and high risk behind, we have to address some of infrastructure issues. Lack of affordable broadband access. Is that something that we think is available in our areas? Do we know how to do that right? And in fact, it looks like we are not doing it at scale. And there's about 120 million individuals within the United States alone that do not have access to broadband. What we've been doing at Microsoft for the past several years has been focusing on this initiative both within the US and globally. It's an initiative called Airband. We right now have over 1.5 million individuals that we've been able to help connect to affordable broadband resources, and that's within the United States alone. Globally, we're talking about 14 million. And it continues to grow in large part because of the need for us to address this as a critical infrastructure need to deliver healthcare. Digital training is another element. We recognize that that has to be in place. We have to start enabling, making it easier for people to set up. And then when it gets to the actual virtual care itself, we're at an early stage. A lot of virtual care is just a video visit. The reality is we can do so much more. When you think about the opportunities to be able to incorporate data, real world health data, to be able to apply analytics and AI on top of it, and so you got decision support, this is a vehicle for us to be able to provide much more sophisticated, better care to the individuals. And we have the tools today. The tools are interoperability, FHIR standards that allow us to be able to pull data into the teams or virtual care environments. We have the AI that can transform that and identify and search and provide recommendations real time, right information at the right time, and allow us to be able to have new platforms for how we collaborate, whether it's through a video visit like Teams, or perhaps even through a virtual type of encounter with care team collaboration through a HoloLens with mixed reality. So it's an incredible opportunity for us to start rethinking what virtual care is and allow us to be able to take advantage of these newer technologies.
Yeah, and I would even go one step further, which is let's reimagine what we think the art of the possible is. Because in the last year and a half, we learned there's a lot more possible that we can actually pull off if we decide to do so. And so Hadas, in this case, in that example that I was giving about that you guys were showing us at Build last year, how hard is it today for you to have a video camera that knows when a nurse goes in and out versus when a patient's family member goes in and out of a patient's hospital room? How hard is it for us to be able to have vital signs monitors, which don't need a nurse to go and scribble on a sheet of paper, for God's sakes, in the year 2021 and enter that into the EHR? These don't look like they require an enormous amount of AI, but it does. Obviously, there's a lot of underpinning stuff. But what do you think could be helped as far as adoption is concerned for these in-room, in-hospital, on-prem kinds of AI and other things that you guys are doing with the ambient voice? What could people start to pick up now rather than wait for 5 years from now?
So all those technologies that you've mentioned are out there, and people can, so organizations can start building solutions, adopting solutions that we are building. One of the things that helped us scale, and I think can be seen also as a best practice. So a couple of things that I want to mention among many. First of all, is extensibility. Each hospital, each care system, each provider, each HMO, each country, they have their own kind of nuances to the process. They do things slightly differently. You need to help them, to enable them to adjust the process, to extend the capability of what you're providing out of the box, and adapt the system while they can leverage what the system offers and still adapt the functionality to their needs, whether it's the speaking in the language of the country, or whether it's just different flows because this country or that provider is doing things slightly differently. So that has been key to adopting those technologies. Another thing that to keep in mind as you develop such systems is remembering that you need to train your systems on as diverse as possible data. whether you're training on different types of texts coming from different modalities or different sources, or even different countries or parts of the countries, or different population or ethnicities, whether your training systems that are aiming to recognize voices or images, you must diversify your training set. You must have it as broad as possible, because otherwise systems will just get broken if they don't operate on the exact same thing they were trained on. And this is something that that is key when you're building AI-based systems.
Right, and as you were talking about these differences in the countries, endpoint production came to mind for me, because when you're at a hospital or health system, not everything can be in the cloud, right? Sometimes you're going to need a device, a thing, a piece of software at the edge, and we call we call that edge computing these days. So you can move a lot of AI and things like that into the edge. One big problem with moving anything to the edge is there's a big issue with cybersecurity. There's a big issue with knowing whether, if the device was stolen, did you take away all the data there as well. I know Gartner mentioned you guys in your quadrant leader, the Magic Quadrant, as a leader in endpoint protection. How important is endpoint protection for the healthcare sector versus any other sectors, Hadas? And then we'll jump to Tony. Ask the question about what does AI mean to patients today?
We see that as quite important, because even though cloud services are growing in adoption and there's a lot of trust in the cloud, a lot of healthcare organizations, especially when you're looking at the PHI, the patient identifiable information, they would rather have those within their trust boundaries. Mm-hmm. So they would want to deploy something that is on-prem or on their cloud subscription, cloud environment, so that the data doesn't leave the service. So this is something, if you look at our cognitive services, for example, they are all offered also as container mode, meaning that you deploy a container on your premises so that your data doesn't have to cross this trust boundary and be sent to the Microsoft endpoints on the cloud. We see, I personally work with a lot of healthcare organizations as customers, and they love this container option.
Mm-hmm. That's fantastic. Yeah, absolutely. And so the endpoint protection is very important in the cloud. And then so especially for the audience that wants to do more and more inside their facility, just remember about edge computing. There's a lot of movement going on in that. Edge and endpoints aren't identical, but they have a lot of commonality. So if somebody protects endpoints well in the cloud, they can generally help you protect edge computing devices as well. So with all this technical stuff, Tony, I'd love to bring you back in. Ground us now, dealing with patients day to day. Where should they see tech, and where is it supposed to kind of like disappear, like David said a little while ago? Because sometimes I feel like patients want to see the tech. They want to know that this is an advanced facility doing things. Where do you feel like they should see it, and where should it disappear behind the scenes in the case of AI?
That's a really good question. That's a challenging question too. I'll start off by saying that a patient and provider, and I'm specifically speaking with my nursing cap on right now, but patient-provider relationships are very symbiotic. So when the patient's affected, the provider's affected. When the provider's affected, the patient's affected. We know that to be true. And just speaking in terms of AI, since we're on that topic, if you think about AI in terms of like nursing care delivery models or care delivery models, I think there's application in both the inpatient setting and also in the care management setting. And this might be something the patient necessarily doesn't see because it's behind the scenes, but what they would see is how the application of AI and the use of all of this data that we're generating really would free up the clinician or the provider to spend more time taking care of and focusing on the patient. And this is what we're missing, and we've gotten so far away from it. And technology has overpromised and underdelivered in that place of where we said it's going to make your life easier. Because I think today, the last time I read a statistic on this, nurses are spending about 30% of their 12-hour shift either documenting in the electronic health record or entering another system to check various forms of data. That's 30% of time that they're not caring for patients. So we have to liberate them and free them to get back to that. So applications of AI where, you know, there could be some predictive modeling that would allow the nurse to understand which patients need care now, who is most at risk, who is, you know, under threat of having an adverse event. Also, where a patient would see technology is perhaps the use of wearables and how that also ties into AI, because wearables, you know, can tell the machine or the computer a lot about what that patient's doing and what that patient is experiencing, and take that into account. And that then, you know, can lead up to these ways for the nurse to understand and head off an adverse event. So those are just some very concrete examples of the application of AI and technology where a patient might see it and where they wouldn't necessarily see it, but they would see that my nurse is back in my room and my nurse is caring for me and my nurse is there one-on-one.
No,
And
I
that's
love
the
that.
goal. That's our goal.
Yeah, that's a great goal. And in fact, you know, nurses, I've been in the nursing informatics business for a number of years, building tools for nurses. They are some of the most flexible human beings literally on the planet. That's a great thing for facilities, but it is also one of the reasons why on the technical side, we just assume, oh, I can just build whatever I want. You know, Nurse Tony will take care of it. Obviously, that's a bad design philosophy, and we should rethink that as much as we possibly can. With that, you know, we've had some great discussion here. We've got some questions coming in. I have a question from Vinny. She asks, most of the clinical integration platform depends on creating a unique patient identifier to be able to build a 360-degree view of the patient from clinical standpoint, incorporating things like social determinants of health, et cetera. In the absence of a national patient identifier, Vinny asks, is Microsoft providing services that can reduce the burden that healthcare IT is facing? David, I'll start with you, but you're welcome to kind of like bat it to anybody else as well.
And this is a great question. And in fact, I don't know if we have a simple answer, unfortunately, because this is a challenge that we run into all the time. I can tell you the steps that will help us get there. First step is around interoperability and enabling consumers to be able to own and manage their own care. So it relies less on the individual system to be able to communicate with each other, but now allowing the individual patients. We saw with the 21st Century Cures Act and the CMS interoperability rules, the ability for individuals, consumers, to now be able to get access to their medical records. And with the same framework, the smart health card framework, they can get access to their vaccination records, the lab test results. And so what we're looking at now are consumers empowered with their own data. And if they can serve as their own, we'll call it personal HIE, to be able to bring and deliver this to other systems that are able to read using the same standards, it gives us an opportunity to start understanding how we can better enable a more freer flow of information. But this time, it's no longer in control of your healthcare provider or your EHR or your payer, but it's in control of the consumer. And that's an exciting movement that we're seeing a lot of traction. And I think that by building off of that and starting putting into trust network frameworks and a variety of other things, it'll allow us to be able to start building that infrastructure that can support the things that we need to do. But unfortunately, it's going to take some really hard decisions to do it on the enterprise side. But if we disrupt it by enabling consumers to be able to have access to the information and manage it themselves, then it allows us to be able to start rethinking what this new infrastructure can look like.
No, I think that is a great point to talk about, because for those of you that were at the Apple WWDC, which is a Worldwide Developer Conference last week, Apple announced their pieces of the consumer-mediated health interoperability puzzle, which was to add medical record sharing and requests through iOS. I think once Microsoft adds that, I think once Google starts to add similar kinds of capabilities, us waiting for the government is probably not the right approach. We're going to have to take some of this internally, figure out how to make it happen. But I believe the key is exactly, I think, what you're saying, which is consumer mediated rather than institutional or health information exchange or other mediated. And once you have consumer mediated, then you can use what the consumer is willing to share with you anyway. Hadas, do you think that that's a reasonable go forward plan, or there's more from the patient identifier problem that we can solve on the technical end?
Yeah, so I definitely believe that there is much more than we can solve on the technical end. And I actually want to talk about an example that's close to heart, and it's related to text data. If we look at the last 2 years, more data was created in the last 2 years than in the previous 5,000 years of humanity. It's hard to believe it, but it's true. To understand all this data and extract information from this, healthcare organizations need smart tools, they need smart algorithms to understand it. A lot of this data is unstructured text, and this is a gold mine. It's a gold mine that was not fully used or leveraged to extract and understand and learn from and support decisions. And when I say unstructured text, I'm talking about clinical notes of different types, clinical trials, protocols, medical encounter transcript, medical publications, discharge notes, admission notes, progress notes, procedure notes, radiology reports of different types. Sometimes this raw text is digital. Sometimes it's even on paper if it's historic. If we want to learn from this data to support decisions, to actually take this to the next level, we need to be able to make sense of this unstructured text, understand it, and structure it. One service that we are shipping early next month in SGA is generally available is Text Analytics for Health. That's our NLP service for extracting insights from unstructured clinical documents. It's capable of understanding concepts through named entity recognition. So it understands clinical concepts in the text, it links them to the relevant clinical coding systems, it understands relationships between those concepts, understand whether they're being said as positive or likely, or whether they're negated, like was not found or did not have fever, and whether they're said in the context of the patient or about somebody else, like a family member, whether they're just mentioned hypothetically or whether they reflect what's written in the paper or in the text. All of this enables things like clinical insights, operational insights, and allows you to dive much deeper into what this historic data has to offer, because now you can also create predictions models from it and analytics and start planning according to those things. So being able to identify the user, of course, is important. It's table tech, but there are so many more things that you can do on the population level, but also on the individual level.
Yeah, it's a fantastic summary. It's a great way to close out. An hour has flown by already, so we're out of time here. So I wanted to thank Microsoft, of course, for making such high-powered senior executives available to talk to us and our health impact audience. But I'd also like to call out the fact that next week we also have another Microsoft event which we are hosting. Tom Laurie, who is the author of AI in Healthcare, he's going to be joined with Mohammed Ahmed from Kensai and Iksa Her from Microsoft. We're going to be talking about the trustworthiness of AI. So if AI is all over the place, what about fairness in the AI? What about trustworthiness? How do you make it explainable? So we're going to be diving a little bit deeper into the AI side. So if you didn't get enough of the AI feel from the team today, please do join us for that next week. Of course, the link is in the chat. Click there, register, and join us. and for next week. But today, on behalf of David, Hadas, and Tony, I want to thank you all for joining. If you have any other questions, please email them to us. We'll make sure that the speakers and the panelists receive those. We've got a bunch of questions, and if we can, we'll be taking clips from this and answering these questions on LinkedIn and other social sites as well to keep the conversation going. So if you disagreed with anything that we said here, tell us on LinkedIn, tell us on email, let us know what whether we're doing what you guys want as far as the audience is concerned. With that, we'll just get away from everybody, and we will let you all go.